Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the neurology side, we'll be talking about another common condition which you will come across in your everyday practice. And this will be one of the reasons which will increase your intracranial pressure and can end up with herniation and mortality, right, death. And cerebral edema will also produce a damage to the cerebral hemisphere and may produce localized sign to an extensive generalized signs. So we'll be talking about cerebral edema. There are different types of cerebral edema. So this is a very important chapter which you should understand because there are a lot of conditions which can lead to cerebral edema. Now we know very well we'll be discussing under this heading definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. Now we know edema is an excessive collection of a fluid in an extracellular compartment. But in cerebral edema is an increase in brain water content which is approximately 80%. So if there is a more than 80% of water content in a brain, we'll call that as an edema. It can be intracellular collection or extracellular collection or both. It can be inside the cell or outside the cell. So cerebral edema is an abnormal accumulation of a fluid in a brain cell and or extracellular space, and that will be resulting into neurological symptoms and signs. So because of an abnormal collection of a fluid, there will be increase in the size of the brain, and that will increase intracranial pressure, and that will be ending up with clinical symptoms and signs, and finally herniations. So to put them into a different group, usually we use 5 common names: vasogenic edema, cytotoxic edema, or also called as cellular edema, interstitial edema or hydrocephalic edema. Fourth group, osmotic edema or hypostatic edema, and fifth, hydrostatic edema. But apart from these 5 groups, you can develop an edema due to traumatic injury and edema due to tumor, but that is good number of time. Tumor and trauma will be indirectly a type of cytotoxic edema. So there will be good number of time mixture of cytotoxic plus vasogenic also. So we'll be going through those different varieties of edema. So basically we have got 5 types: cytotoxic, vasogenic, osmotic, hydrostatic and interstitial. Interstitial is also called as hydrocephalic edema. So etiology wise, it can be neurological or non-neurological conditions which can produce edema, cerebral edema. Among neurological conditions, ischemic stroke, brain tumors, intracranial hemorrhage, meningitis, that is inflammatory condition like meningitis, encephalitis, or other brain infection like cysticercosis, tuberculosis, toxoplasmosis. And among non-neurological conditions like diabetic ketoacidosis, hypertensive encephalopathy, or also previously it was called as malignant hypertension. Now we also use the word hypertensive emergency. Then fulminant viral hepatitis, hepatic encephalopathy, hyponatremia or SIDH, and opioid drug abuse. This will be non-neurological groups. You can divide them into trauma, tumor, inflammation, ischemia, hypertensive encephalopathy. There is one odd condition we call as a mountain sickness, or we call high altitude cerebral edema, short form we call HACE, HACE. and even nitric oxide can produce damage, and that can also result into cerebral edema. Among some odd toxins, isoniazide, hexachlorophene can also produce cytotoxic edema. Reye syndrome, severe hypothermia, early ischemia, encephalopathy, early stroke, hypoxia, severe hypoxia, cardiac arrest, pseudotumor cerebri. These are the other conditions which can produce cerebral edema. This condition will give rise to cytotoxic edema, while trauma, tumor, focal inflammation like meningitis, etc. will give rise to vasogenic edema. Even hypertensive encephalopathy, that will be vasogenic, while this will be damage to the cells, so it will be cytotoxic edema. We usually come across these two groups of edema. We call cytogenic or cytotoxic and vasogenic. And edema because of mountain sickness or accelerated hypertension or hypertensive encephalopathy. These are usually hydrostatic variety of edema. And osmotic is mainly because of plasma when it is diluted by several mechanisms like SIDH or hyponatremia, or maybe because of hemodialysis or hyperosmolar hyperglycemic state, then this can end up with osmotic variety of cerebral edema. Interstitial edema is usually because of obstructive hydrocephalus. Hence it is also called as hydrocephalic edema, where there is a rupture of CSF blood-brain barrier system and the fluid will seep out of a ventricular system into the interstitial space. Hence it is also called as interstitial edema or hydrocephalic edema. And this is one variety where it is secondary due to hydrocephalus. So it is a interstitial cerebral edema, differs from vasogenic edema as CSF contains almost no protein, because here it is not due to any inflammatory mechanism. So classical example of cytotoxic is which produces damage to the cell wall, and potassium sodium pump is being damaged, like ischemia, trauma, toxins, metabolic disorders, etc. While vasogenic is secondary due to break in blood-brain barrier system, and that will produce by infection, tumor, hyperosmolar states and inflammation. And interstitial is because of hydrocephalus. These are the three common variety of edema. When you get because of brain tumor, it is usually one of the cause of what we called as vasogenic edema, but some people put it separately, that cerebral edema due to brain tumor. So that will be one variety which you can put separately, and it is because of disturbances in blood-brain barrier system, weakness of the blood-brain barrier system. If we come to the pathophysiology, we'll be talking separately regarding cytotoxic, vasogenic, hydrostatic, osmotic, as well as hydrocephalic. But at present, this is one slide where I can explain you regarding diabetic ketoacidosis. So in a diabetic ketoacidosis, because of high blood urea, because of dehydration, because of acidosis, hyperventilation, and because of hyperventilation there will be low PCO2, and all these factors together that will result into vasodilatation, and there will be formation of cerebral edema. This will be one of the mechanisms which will be taking place in case of a diabetic ketoacidosis. These are the risk factors, and these are associated things which happens with diabetic ketoacidosis, like dehydration, acidosis, hyperventilation. But the risk factor will be high blood urea, low PCO2, and when you treat with bicarbonate, you can also end up with cerebral blood vessel vasodilatation. Because of cerebral edema, there is increase in the brain mass, and that will give rise to increased intracranial pressure. And because of increased intracranial pressure, blood perfusion is being disturbed. So cerebral perfusion pressure will be disturbed because there is increase in intracranial pressure. So CPP will be reduced, and because that is reduced, it will give rise to ischemia and later on necrosis, and that will be giving rise to local neurological symptoms and signs. So because of cerebral edema, increase in water content of the brain, increase in intracranial pressure, neurological deterioration, and when the pressure becomes more than certain limits, then you will start getting shifting of the brain tissue. We call that as a herniation. And in case of tonsillar herniation or herniation of the cerebellum, then it will give rise to death. If you understand very shortly and briefly, in vasogenic cerebral edema, it is because of the disruption of the blood-brain barrier system. And this will be very typical in case of trauma, tumor, that group. While cytotoxic, it is due to injury to the neuronal cells or glial cells. So this is a direct damage to the cell wall, and because of the damage to the cell wall, there is a disturbances in sodium and potassium pump, and that will give rise to edema. While in case of a osmolar cerebral edema, it is because of increase in osmolarity in the brain, because external osmolarity is reduced. So plasma osmolarity reduces, brain osmolarity is high. So water will shift from extracellular compartment into intracellular compartment, leading to cerebral edema. While in case of hydrocephalic edema, we are also labeled as interstitial cerebral edema. This, because of increased pressure in the ventricular system, the CSF now leaks from the ventricle to interstitial space outside the ventricle, and this is because of disruption of a blood-brain barrier system. But this is labeled separately because it is secondary due to hydrocephalus. So this is the most simplified form. Yes. So cytotoxic edema is because of influx of a fluid inside the brain cells, while vasogenic is fluid which influx into the interstitial space from a blood vessel. So this is in the interstitial space, while this is in a neuronal cells. Neuronal cells. So cytotoxic edema is because of the damage to failure of sodium potassium pump, blood-brain barrier system is intact, and this will very commonly develop because cell wall damage will develop very frequently to ischemia and hypoxia. So this will be the most common cause of cytotoxic edema. And here gray matter as well as white matter both are affected, and this will usually invariably lead to a massive infarct area, and maximum edema will take place in 48 to 72 hours. And cytotoxic edema, we already mentioned that it is because of increased permeability, because of sodium and potassium pump. Also there is calcium influx is being disturbed. So sodium and water is drained inside into the cell, and we already mentioned that it is because of ischemia, hypoxia. So it is secondary due to ischemia and hypoxia, ischemic encephalopathy, quite common. So this will be the most common cause. And another common cause for cytotoxic edema is traumatic brain injury. While vasogenic edema is because of breakdown of the blood-brain barrier system, which will happen very frequently in tumor, infarction, infection, abscess, etc. And this will disturb mainly the white matter because blood is seeping out from the blood vessel into the interstitial space, and white matter is more affected, and that will give rise to what we call as vasogenic edema. And this is again, we have mentioned, it is very common to tumors, infections, abscess in late stage of cerebral ischemia, etc. And blood-brain barrier system can be disturbed because of arterial hypertension, because of trauma, because of toxins, because of inflammation, because of tumor, etc. So indirectly, vasogenic edema will be because of multiple causes, while cytotoxic edema will be mainly because of ischemia and hypoxia, ischemic episode and hypoxic episodes. While interstitial edema, we already mentioned, it is because of obstructive variety of hydrocephalus, and because of obstruction there is increased pressure in the ventricular system, and because of that now blood-brain barrier system is being disturbed, and you will have a seepage of cerebrospinal fluid from a ventricular system into the interstitial space. So it is because of an obstruction to the outflow of CSF, and that will give rise to interstitial edema, or we call as hydrocephalic edema. Osmotic variety, we have already explained that it is because of dilution of the blood or decreased osmolarity in the blood. Classical example is SIDH, hyponatremia, etc. So in this, or even in a rapid correction of hypernatremia can also end up with cerebral edema. So because external osmolarity is low, intracellular osmolarity is high, so water will sift from extracellular compartment into intracellular compartment, leading to cerebral edema. This is not very common, but quite common in case of SIDH. So this will be a simple mechanism which can be explained. If there is an hypoosmolarity outside, you will have a cerebral cells will swell up, so there will be an edema. And if outside environment is hyperosmolar, then cerebral cells will shrink. So this will happen in hyponatremia, SIDH, in hemodialysis, rapid reduction of blood sugar in diabetic ketoacidosis can also end up with cerebral edema because of osmotic cerebral edema, and rapid correction of even hyponatremia that I already mentioned, or if you give hypotonic solutions, particularly 0.45% normal saline. Hydrostatic is mainly because of malignant hypertension or sudden shoot up of blood pressure, where the autoregulation of cerebral blood flow will be disturbed, and that will give rise to transudation of fluid from a vascular compartment into extracellular compartment. So that will be a hydrostatic variety. So these are all the 5 classical common variety. We already mentioned that in case of a brain tumor, there is a damage to what we call as a blood-brain barrier system, and that can give rise to seepage of fluid from vascular compartment into extracellular compartment. There is one variety we call as a HACE, or high altitude cerebral edema, and this is mainly because of hypoxic damage, and that will give rise to seepage of fluid from intracellular compartment into extracellular compartment. I am doing in short. This is a long chapter, that's why. Now, secondary to cerebral edema in general, because of now fluid collection in a brain tissue inside or outside the cerebral cells, that will increase the size of the brain, and because of increase in the size of the brain tissue, the space occupied in a closed compartment of the skull, which is a bony compartment, hence intracranial pressure will be increased, and secondary to intracranial pressure increase, you will have headache, vomiting and blurred vision, because you will have a papilledema. And when the intracranial pressure increases tremendously, now you will have a shift of brain tissue, and then when you have got shift of a brain tissue, we call that as a herniation. And secondary due to herniation, now you will start developing compression of different parts of the brain with either tentorium or the fox cerebri, and that will compress the nerve, and you will get third cranial nerve palsy or sixth cranial nerve palsy, and you will have a compression of the brain structures, and you will have a neurological symptoms and signs. And when the cerebellum herniates through foramen magnum, we call as tonsillar herniation, and that will compress the medulla, and that can give rise to pulse abnormality, blood pressure abnormality, and respiratory abnormality, and person can even die. So that will be, all those portions will be covering into herniation chapter. At present we will not be doing in detail. So one of the presentation in a very early stage may be asymptomatic, and as the intracranial pressure rises, you can have bradycardia, hypertension, severe headache, person will be irritable, lethargic, altered mental status, nausea, vomiting, visual disturbances with papilledema, and when you get damage to third cranial nerve palsy, sixth cranial nerve palsy, now you can have diplopia, etc. So that will be all the things what will be happening. So headache, tinnitus, vomiting, visual disturbances, visual loss, papilledema, diplopia, hypertension followed by bradycardia, and herniation syndromes. This will be all the different groups which will be presentation. So the most common presentation we already mentioned, that is because of raised intracranial pressure will give rise to headache, vomiting, and blurred vision. But once the herniation starts, now you will have a damage to different parts of the neurological system, and that will give rise to motor findings, sensory findings, cranial nerve palsy, etc. like increased muscle tone, trismus, decerebrate posture, hyperventilation. Because of damage to the third cranial nerve, you will have a dilated pupil, not reacting to light. You will have a oculomotor nerve palsy, opisthotonus. You can have even a little amount of neck stiffness, Cushing triad, which is bradycardia, apnea, and hypertension, altered level of consciousness. Even sometimes person can have focal neurological symptoms and signs, even papilledema, and sometimes even person can have complete loss of vision also. So putting together, because of raised intracranial pressure, you can have altered level of consciousness, papilledema, impaired eye movements, sensory and motor function disorders, bulging of fontanelles, cranial suture separation, head circumference will be increased, but this will be seen in an infants only. Once the suture, cerebral skull suture fuses, then you will not have those bulging of the fontanelles, you will not have a separation of sutures, and head circumference will not increase much. Because of raised intracranial pressure, headache, and because of damage to the third cranial nerve, dilated pupil, not reacting to light, and because of Cushing triad, hypertension, bradycardia, and change in respiration. Vomiting will be one of the common signs of raised intracranial pressure. So headache, vomiting, and diplopia with visual disturbances secondary to papilledema. Usually we call headache, vomiting, and papilledema are the three cardinal signs of raised intracranial pressure. And in Cushing triad, hypertension, bradycardia, and papilledema, along with seizures, altered level of consciousness, and then secondary to herniation, you start getting different symptoms and signs. So as soon as the intracranial pressure rises above 30, you start developing headache, vomiting, and papilledema, blurred vision. And when it becomes more than 40, you start getting herniation symptoms and signs. We'll be talking of herniation syndromes separately. So intracranial pressure is because of the increase in the volume of the brain because of accumulation of fluid. An increase in the intracranial volumes can result into swelling, mass effect, and increase in the blood and CSF volume. Now this particular factor does not play a role in case of cerebral edema. In case of cerebral edema, it is because of the increase in the brain volume. because of accumulation of fluid inside and outside the cell. And secondary to raise intracranial pressure, now cerebral perfusion pressure is reduced, cerebral ischemia will take place, and you can have even necrosis, and that will give rise to neurological symptoms and signs. And once the pressure becomes more than 40, now you will start having herniation, like Falcine herniation, uncal herniation, central herniation, and when it becomes very severe enough, you can have tonsillar herniation. And when tonsillar herniation takes place, it is a dangerous one. So this is cingulate herniation or Falcine herniation. This is uncal herniation. You can have central herniation. Very rarely you will have an upward herniation, that is rare. That will take place only in an infratentorial cerebellar tumors. And tonsillar herniation will be in a late stage. So these are the different types of herniation. We'll be talking in detail when we do a chapter on herniation. And these are the symptom signs in a herniation syndromes. We call subfalcine or cingulate, central tentorial, uncal herniation, tonsillar herniation, and in case of fracture skull, you can have an external herniation when a portion of the skull is missing. I'm skipping this particular part in herniation syndrome, we'll be doing separately. Now this is one slide, I'll take little more time in this because this slide explains you the clinical picture and entire picture of all the 5 variety of cerebral edema. So I'll be going one by one. In cytotoxic edema, cellular metabolism, that is sodium potassium pump, is being disturbed, while in vasogenic, blood brain barrier system is being damaged. In interstitial, there is a CSF leak from vascular ventricular system into the interstitial space. In osmotic, the pathophysiology, because osmotic gradient across the cell membrane, that is intracellular osmotic pressure is high, extracellular osmotic pressure is low, hence there will be shift of water from extracellular into intracellular compartment. While in case of an hydrostatic variety, intravascular hydrostatic pressure is high as compared to extravascular compartment, hence you will have a water shifted from vascular into extracellular compartment. In cytotoxic, cell will swell up, so the size of the neuronal cells will increase, while in case of vasogenic, capillary permeability will increase. In case of interstitial, from ventricular system, because of obstructive hydrocephalus, the CSF will leak from ventricular system out into interstitial space, while in case of a osmotic variety, the fluid from extracellular will shift into intracellular compartment and there will be cellular swelling. So we'll have again a neuronal edema, and in case of hypertension, you will have a shift of fluid from vascular compartment into extracellular compartment. In a cytotoxic variety, mainly water and sodium, no protein, but in case of vasogenic, it will be high protein content, and this will be very peculiar in case of inflammatory damage, inflammation, tumors, etc. While in case of interstitial, mainly it will be more of water, very low protein. Again, in case of osmotic, mainly water, no protein. In case of hydrostatic, mainly water and sodium, no protein. Indirectly, cytotoxic, osmotic and hydrostatic are nearly same. While in case of vasogenic, it will be more of high protein content of fluid outside the cellular compartment, or we call interstitial. While in case of interstitial variety, you will have a CSF containing low protein. It will not be high protein. Good number of time there is no protein. Cytotoxic will involve both gray matter as well as white matter, while vasogenic will mainly involve white matter. Interstitial will involve periventricular white matter, while osmotic will again, like vasogenic, will involve white matter, and hydrostatic will also involve white matter. In case of cytotoxic, it is mainly the extracellular fluid will be reduced. It will be more in intracellular compartment, while in vasogenic, it will be extracellular fluid compartment will be markedly increased. You can see in all three, it will be extracellular fluid compartment, while this will be in an intracellular compartment, while all these three will be in an extracellular compartment, while cytotoxic will be mainly in an intracellular compartment. Blood-brain barrier will be intact in case of cytotoxic. In case of vasogenic, it is disturbed, while in interstitial, osmotic and hydrostatic, blood-brain barrier system is not affected. Steroid will be effective in case of vasogenic, but it will have no effect in case of cytotoxic, interstitial, osmotic or hydrostatic. So only in case of vasogenic you can try steroids. While diuretic will be effective mainly in case of vasogenic and in case of osmotic variety, but it will be minimal effect. While temporarily, that is for transient period, cytotoxic, interstitial and in case of hydrostatic, this may be diuretic may be helpful. So it is a very transient effect. This is a very good slide. At your leisure time you can go through, you will understand all the 5 different varieties of cerebral edema. Same thing explained in little more detail. At your leisure time you can go through. Almost majority of the thing is explained in a very simplified way in this particular slide. Here it is a comparison of 4 varieties: cytotoxic, vasogenic, interstitial and osmotic. This is again same: vasogenic, cytotoxic and interstitial. Almost we have explained. Here there is one more explanation, that mannitol will be effective more in vasogenic and in cytotoxic, but in an interstitial variety it will be of no use. So mannitol is not indicated in interstitial variety and also not indicated in hypertensive encephalopathy also. It is not much beneficial. These are few slides. Now as far as diagnosis is concerned, it is quite easy, that any person in whom you get a classical triad of headache, vomiting and blood vision, and on fundoscopy you demonstrate there is a papilledema, that is a symptom signs of raised intracranial pressure. And now you look for the different symptom signs of brain involvement in the form of altered mental status, seizures and other symptom signs of herniation. You should suspect a person might have cerebral edema. And cerebral edema will be diagnosed by CT scan. You can go for optic nerve ultrasound, and fundoscopy will be very, very helpful. And to find out the raised intracranial pressure, you will have to go for invasive intracranial pressure monitoring system. Mainly to differentiate in a CT scan between cytotoxic and vasogenic. As cytotoxic gives rise to exudation of fluid into, because of damage to the sodium and potassium pump, there is a damage to the cell wall. So fluid is going inside into the cell, so it involves the gray matter as well as white matter. So as it involves the gray matter and white matter, it is almost a broad shape, cone shape, wedge shape it is called. Periphery is broad, center is little short. So it is a wedge shape like of hypodensity area, hypodense area, right from ventricular system up to the periphery. While in case of vasogenic, as it is a damage to the blood-brain barrier system, it affects mainly white matter, and it is because of exudation of fluid into the interstitial space, or we call extracellular space. So it occupies the extracellular space and it gives rise to finger-like pattern, very, very typical, and it does not extend right up to the external, what we call as a gray matter area. So it is mainly involving the white matter area. So this is a typical CT scan picture, can tell you vasogenic from cytotoxic. Again repeating, cytotoxic most common cause is because of ischemia and hypoxia, while vasogenic is very commonly because of tumor, trauma, infection that will produce vasogenic. So now here you can see this is nearly a quiz. You can see this looks like a finger. You can see this. This is a hypodense area. So it is like finger like. And if it is finger like, we already mentioned, it is vasogenic. So this will be vasogenic. While you can see here, the entire area, right from here, it is a cone shape, nearly like a cone shape or wedge shape we call. This is a broad area, and here you can see this entire is a hypodense area. This will be ischemia, or we call infarct, and that will be very typical in case of cytotoxic. Clear? So this, you can see here, this looks like finger. So this will be cytotoxic, and this looks like a very broad area, right from center till periphery. So this will be cytotoxic. So CT scan will help you a lot. Monitoring of intracranial pressure. ABG will be also helpful. Lumbar puncture is usually not indicated. Only in case of suspicion of infective pathophysiology or hemorrhage, you will go for lumbar puncture. Echoencephalography is a non-invasive technique. It is very, very helpful. And you can even go for echo of, we call optic nerve. This is cytotoxic. And that one is, this is also cytotoxic. This will be vasogenic. This will be vasogenic. So this will be vasogenic, and this will be cytotoxic. Cytotoxic, you can see a very big area, right from center till periphery. Well, this will be finger-like vasogenic, broad, wedge shape, cytotoxic. Here you can see this is finger-like. So this will be vasogenic, and when it is broad shape, this finger-like, vasogenic. Again, very, very easy. You can see finger-like. So this will be vasogenic. And when you get, see here, this is some neoplasm or abscess and surrounding area. So this will be cytotoxic. Cytotoxic. Again, you can see this. Cytotoxic. This will be very big area. You can see a very big area. So this will be vasogenic. You can see this again. This is like an infarct. Cytotoxic. This is finger-like. So vasogenic. Now you can see here, this is a very huge enlargement of ventricular system. And secondary to ventricular system, this will be hydrocephalic or interstitial. So we are skipping this particular slide. We are not much interested in knowing in detail, but you should be aware of CT scan or MRI is very, very useful in identifying the difference between cytogenic and vasogenic. And you can go for what we call as T2W and T1W. So that will be helpful in some good number of times. Now this particular will be cytotoxic. This will be vasogenic. So this will be cytotoxic, cytotoxic, cytotoxic. This will be vasogenic. You can see finger-like. So vasogenic. And interstitial will be with hydrocephalic. Again, you can see this finger-like, vasogenic. This is wedge shape, cytotoxic. Wedge shape, cytotoxic. Finger-like, vasogenic. Differential diagnosis, mainly you will have to differentiate other causes which gives rise to raised intracranial pressure. But almost in all these conditions, you will have cerebral edema. Management comes mainly for different things what happens because of cerebral edema. Cerebral edema will give rise to raised intracranial pressure and herniation. And that can raise intracranial pressure, treatment will be there. So for that, optimizing the head and neck position, ventilation and oxygenation, intravascular volume and cerebral perfusion should be improved. If person is having seizures, prophylaxis for seizure, management of fever and hyperglycemia, because diabetic ketoacidosis is one of the very common cause for cerebral edema. Nutritional support. Now, as far as pharmacotherapy is concerned, volume resuscitation. Corticosteroid will be helpful in case of tumor, which is going to give rise to which variety? Vasogenic. Diuretic is not very useful. It will maybe partially helpful in case of osmotic variety. And osmotherapy is also not indicated in, usually it will be dangerous good number of time in good number of conditions. But when pharmacotherapy doesn't work, you might have to go for non-pharmacotherapy like surgical decompression, that is craniectomy, head of the bed elevation, hyperventilation, etc. Now little bit in more detail. Head elevation, midline head position, drainage of CSF via ventriculostomy, osmotherapy, that is mannitol or hypertonic saline. This is, you have to think over in a person who has got congestive heart failure, previous ischemic heart disease, CKD. In those conditions, mannitol and hypertonic saline will be contraindicated. Glucocorticoids will be very helpful in vasogenic edema because of tumor, abscess, those groups. Hyperventilation will help you because by hyperventilation you bring down the PCO2 to below 30 to 35 millimeter, and that will produce vasoconstriction, will reduce the edema. Vasopressure can be utilized in some groups like dopamine, norepinephrine to maintain the mean arterial pressure, to maintain the perfusion, and that will improve little amount of symptoms and signs in case of cerebral ischemia. But it will be dangerous in person who has got hypertensive encephalopathy or malignant hypertension, or we call it hydrostatic edema. Once the raised intracranial pressure is refractory to pharmacological therapy and some of the non-pharmacological therapy, you will require decompressive craniectomy. Some of the things which may be helpful is called pentobarbital coma or phenobarbital coma, that will reduce the metabolism of brain, and even hypothermia. If you reduce the body temperature to 33 degrees centigrade, that will be also helpful in a person with a raised intracranial pressure. So sedation, position, hypertonic solution, steroids, hyperventilation, hyperbaric oxygen, hypothermia, and barbiturate coma. These are in general the different modes of treatment in raised intracranial pressure. So right from sedation, positive pressure, ventilation, osmotherapy, hyperventilation, phenobarbital coma, hypothermia, and last resort is surgical intervention. So osmotherapy mainly by hypertonic saline or by mannitol. But while using this, you have to keep a watch. Diuretic usually is not a common choice. It may be helpful in case of what we call as SIDH. We already mentioned steroid will be helpful in case of tumor and in case of meningitis, brain abscess, those groups. Hyperventilation is another treatment which will, by hyperventilation, you bring down the CO2, which will produce vasoconstriction. So if you bring down PCO2 to 30, there will be vasoconstriction and it will reduce cerebral edema. And surgical treatment is a last resort. And in surgical treatment, you can go for mainly the earliest thing what is being commonly done is a craniectomy. You can go for VP shunt, CSF drainage, ventriculostomy, and if the person has got tumor or a brain abscess, drainage of brain abscess or drainage of hematoma or removal of tumor will be one of the treatment in case of SOA. While non-specific treatment like antipyretics, sorry, the spelling is wrong. This A should not be there. Barbiturates, glucocorticoid, diuretic, and hyperosmolar, or we call as hypertonic saline or mannitol. These are non-specific treatment. You have to think of clinical condition and then use it. So mannitol, glucocorticoids, hypertonic saline, depending upon the condition, you have to decide. We already mentioned that you will have to elevate the head to 30 degree, then cerebrospinal fluid diversion by surgical treatment, etc. Surgery, temporary ventriculostomy, craniectomy, decompressive craniectomy, VP shunt are common procedures. This is a guideline. What is a Glasgow Coma scale, and depending upon that guidelines, you can follow this guideline. At your leisure time, you can go through. This is VP shunt which is being done, and it will reduce intracranial pressure very nicely. It is one of the most common treatment done in children. This is VP shunt, ventriculoperitoneal shunt, very common. As far as complication of cerebral edema is concerned, herniation, seizures, neurological symptoms and signs, coma, and once the tonsillar herniation starts, the chances of death will be very high. So I end my lecture here. So I thank you all for taking out time. I know that your time is valuable, and I appreciate that for spending some of the time with me. If you feel that this lecture is very helpful to you, don't forget to press button like, give your suggestions so that I can improve, I can make it more beneficial to you. This will be very helpful to you in your everyday practice. If you pick up these cases and pick up them in an early stage and refer them to an expert, you can help them out and you can decrease the mortality as well as morbidity. If you feel this lecture is helpful to you, you can share with your friends also. See you in next lecture.